Hello and welcome to Season 2, Episode 55 of the Physician Assistant Exam Review Podcast. This week we're going to continue with pulmonology, and in particular we're going to be covering pulmonary circulation. My name is Brian Wallace. I'm the host and creator here at Physician Assistant Exam Review. And over at the website, www.physicianassistantexamreview.com, you can find all the notes, a whole host of resources over there. And this week, something in particular, a little better for you because next week is PA week. So I wanted to kick it off a week ahead of time and get out in front of that and have some really great stuff for you. And I'll get into that a little bit more towards the end of the show today. But if you go over to www.physicianassistantexamreview.com/PA week. I've got some great stuff getting started for you starting right now, today. So hop on that. And again, I'll talk about that more towards the end of the show. This week, we're going to be covering, continuing with pulmonology. We've been working our way through pulmonology in general. And this week in particular, we're going to be covering pulmonary circulation, which is, to be quite honest, a section of the blueprint that I am not entirely comfortable with, that I have a little trouble wrapping my head around. That is not my favorite, doesn't come naturally at all to me. In fact, on my, at least on my most recent PANRE, it's the section I did the worst on was pulmonology. So this is something that I struggle with a little bit, and we'll see if we can help to improve both of our performances moving forward. So let's start off with our priming questions for today. See if any of these ring a bell for you. They certainly didn't for me again. What is Virchow's triad? What is Virchow's triad? Define cor pulmonale. Define cor pulmonale. And lastly, what is the treatment for pulmonary hypertension? Just take a minute and think those three through before we move on and explain them all to you, because it takes a minute. I want you to try to drudge up some of this stuff in your brain. If you've heard it before, if you've covered any of it in lectures, just take a minute and see if you can come up with at least one. What's Virchow's triad? So you know triad is 3. What's one of the things in there? And what are we even talking about? Define cor pulmonale, and then what is the treatment for pulmonary hypertension? All right, so our 3 topics for today are going to be pulmonary embolism, pulmonary hypertension, and cor pulmonale. And they run together. These are sort of the issues on the blueprint that have to do with pulmonary circulation and issues with pulmonary circulation. So we're going to start with pulmonary embolism, which to me is easy to get your head around, right? This is the one from this group that I feel very comfortable with. And this is a blockage of a main artery into the lungs by something that has traveled from somewhere else in the circulatory system, right? So usually this is we associate this in our heads with the DVT, deep vein thrombosis. The embolism comes from the leg through the heart and then gets lodged in the lungs. So that's our pulmonary embolism, is something lodged in the lungs, preventing the circulation of blood through the lungs, right? Obviously, if we can't circulate blood through the lungs, we're not moving oxygen into the blood and not moving that oxygen out into the rest of the body. Major issue, major problem. Risk factors. Virchow's triad is our main source of risk factors here, which is immobility, hypercoagulable state, and vessel injury. Those are our 3 things in Virchow's triad. Immobility simply means you're not moving. Hypercoagulable state, there's a couple different reasons for this. Cancer is always a good one. Surgery is always a good one. But there's a number of reasons why you might be hypercoagulable. And vessel injury. So that's the one that rings a bell for me, is always surgery, because that's what I do. So you're at an increased risk of PE following surgery. You're at an increased risk of DVT following surgery, right? So it's always something that's on our minds in the surgical realm. We're always worried about DVTs and PEs. So we're trying to prevent those. We're trying to get people up and moving. We'll talk a little bit about that in just a second. So clinical presentation for a PE, and it's going to be similar for a bunch of these, because if you think about how they function, how they work, chest pain, right? So if you have a pulmonary embolism, you're going to have chest pain. You're going to have a blocked artery in your lungs, right? So it's going to hurt. You're going to have dyspnea, and hemoptysis is possible. Physical exam findings, tachypnea and tachycardia are big clues. So if I see a patient the day after surgery and they're breathing quickly and they have increased heart rate, I'm definitely concerned about a PE. You can do an EKG, and they're usually normal, but you may have a nonspecific ST changes. A lot of times people are hooked up to a oxygen monitor, so you may see hypoxemia. On a chest x-ray, there are two findings that you may come across that jump out in the textbooks about PE on chest x-ray, which are Westermarck sign and a Hampton hump. I'm not really sure how they would ask you about either one of these. As I read through the descriptions, it's a little tough. They may show you a picture, but boy, that would be really tough. So our Westermarck sign is hypovolemia distal to the PE, and a Hampton hump is a wedge-shaped opacity due to lung infarct. So you can look up some pictures online and do a little more reading on that. I just think it would be very difficult to write a question where those are your answers. Just very, very difficult. There's a lot of things on PE you're going to write a question about, which would be things like the type of patient. You're going to give clues as far as hypercoagulable states and all that stuff. And that's going to be more how I think this question is going to come at you. I think it's going to be less something that you're going to evaluate through labs and studies. Anyway, you may also see atelectasis on a chest x-ray. Historically, it was a ventilation perfusion scan for diagnosis, but now we're getting more toward helical CAT scans, which do require contrast dye. So that is an issue. I know we had a patient last week who had an issue with contrast dye, and there was some question that they may have a PE. So there was some going back and forth whether it would be the best way to handle that situation. But anyway, a helical CT would be the main way we're going to diagnose. And then a pulmonary angiography is going to be a gold standard, but we're probably not going to wind up doing that. Treatment: anticoagulation for 6 to 12 months. Heparin you can start right away for immediate treatment, and then warfarin or something for longer-term treatment. There are a couple of different options. We're not going to go into them here. Thrombolytics would be an option if you had sort of an emergency situation, and you could do an inferior vena cava filter if this is an ongoing issue and you're constantly throwing these PEs from your legs. A better form, though, under treatment is prevention, right? So it's something we're constantly working on on the floors following surgery. We want patients up and moving as much as possible. We want people not laying in bed. We hook up the sequential compression devices to their legs, which create this squeezing. Most of you have seen these. It's kind of a stocking that blows up. It's like it's like a blood pressure cuff on both legs. It goes up intermittently, and we hook that up as soon as the patient lays down in the bed for surgery, because they're not moving now, right? So they're not getting the blood pumping through their legs. They're getting stasis in the veins. So we hook those up to push blood through the veins using because the muscular pumps aren't going to do it if the patient's not moving, right? So that's SCDs. Then we get patients do ankle pumps if they're in bed and the SCDs come off. And we make sure they're up and walking to make sure that is not an issue. And then patients will oftentimes get aspirin postoperatively or Lovenox, but I think it's moving more and more toward aspirin, 325 BID, something like that. And that's all for prevention of DVT, prevention of PE. All right, next we have pulmonary hypertension. So this is elevated pulmonary artery pressure. Okay, so very straightforward. The definition is simple. Elevated pulmonary artery pressure. So the arteries in the pulmonary circulation, we have an increased pressure here. Two types, as always. We have idiopathic or primary pulmonary hypertension, and we have secondary pulmonary hypertension, which means something else is causing it. Idiopathic is rare, and it's more commonly found in young women. Secondary pulmonary hypertension is caused by anything that increases vascular resistance throughout the lungs. So left-sided heart failure can increase resistance in the lungs, right? If you get back up into the heart, back up into the lungs, you can get increased resistance in the lungs. Lung diseases like COPD can cause increase in vascular resistance throughout the lungs. A pulmonary embolism is an example of something that can cause an increase in increase vascular resistance in the lungs. Clinical presentation, again, exertional dyspnea and chest pain. So you can get this shortness of breath. You can get lightheaded. You can get exertional syncope also, depending on how bad this is. But if we have that increased resistance and there's less and less blood going through the lungs, you can picture what some of the problems here would be and how a patient might present. On physical exam, you might hear a splitting of S2. You may see some cyanosis, that bluing in the fingertips and the extremities, and you may see signs of right heart failure, which would be peripheral edema, ascites, elevated jugular venous pressure. Right? If we have increased resistance in the lungs, vascular resistance, you will get a buildup back into the right heart. You can get right heart failure. EKG will show right axis deviation, secondary to right-sided enlargement. Chest X-ray will show right heart enlargement. And a CT will show enlarged pulmonary arteries, and an echo here is going to be helpful. A gold standard for diagnosis is right heart catheterization. Treatment here is not particularly good. So along with pulmonary hypertension, there is a 5-year survival rate about 50%. 50%. So not great. If this is a secondary pulmonary hypertension, you're going to treat the underlying causes. So if you can alleviate the left-sided heart failure, if you can alleviate the COPD, the pulmonary hypertension should get better, right? It should improve. There are pulmonary vasodilators. I'm not going to go through them here. Those can be used, which will target more the pulmonary blood vessels. Those may or may not be effective depending on the type of hypertension, the cause of hypertension in the lungs. And then eventually we wind up with a lung transplant, which obviously has a lot of hoops to go through, is not an easy surgery, and the survival rates there are not 100% either. And then our last topic for today, cor pulmonale. This is right-sided heart failure secondary to severe pulmonary disease. So right-sided heart failure secondary to severe pulmonary disease. So if you think about it, the right side of the heart pumps blood into the lungs. If the lungs are made out of concrete, like in sarcoidosis, and they're all scarred up, the blood doesn't push through as easily and as nicely, it gets backed up into the right heart. And you can wind up with a right heart failure if that resistance is too high for too long. So some of our causes, I just mentioned sarcoidosis, things that cause some scarring in the lungs. Acute respiratory distress syndrome would be another one. A PE would be another one. COPD, severe asthma, and then lung trauma, including surgery. Anything that's going to cause like markedly increased pressures in those lungs, in the vasculature of the lungs, can over time cause cor pulmonale. And if we bring up clinical presentation, again, this is one you should be able to think through. This is not something you should memorize, right? This is something that should be very obvious to you. You can get dyspnea, wheezing, chronic wet cough, edema, and cyanosis. On our physical exam, again, cyanosis and clubbing may be present depending on how long it's going on for. Ascites and edema. Increased JVD. On EKG, you can get tall peaked T waves, which represent right atrial hypertrophy, right axis deviation. And on a 12 lead, you can get a lead 1 has a negative QRS, and then AVF has a positive QRS. Again, because of that right heart, that right atrial and right ventricle hypertrophy. A chest X-ray, you can get an enlarged right ventricle. You may see that on the chest X-ray. You may see enlarged pulmonary arteries. On an echo, you can see right-sided hypertrophy and dysfunction. And then you're going to want to do some pulmonary function testing on these people as well. Treatment here, again, if our issues with pulmonary hypertension were not great, our solutions for cor pulmonale are even less so. Some oxygen may help, and then treat the underlying lung disease. So if you can clear up, again, the COPD, the asthma, the sarcoid, the PE, those sorts of things, if you can clear that out, you will help that right-sided heart failure. But without that, it's going to be an uphill battle for sure. All right, so that closes out pulmonary circulation for us. Again, I just sort of struggle to see how you would come up with test questions in this section. And maybe that's why I didn't do as well in this section, because I just don't see it as clearly. There are certainly things you could ask. There are certainly things you could go over. But it's not something that I feel like lends itself easily to test questions that we should be able to answer as PAs, as a person taking the national certification exam, when we're not talking about the details of treatment for some of these things. We're just talking about identifying them. It becomes a little more difficult to write test questions on them. So I would approach it, or rather I did approach it that way. And like I said, I did knock it out. I did not knock it out of the park on this particular one. So, take that with a grain of salt and what you will. Anyway, let's move right along. We're going to talk about our study tip of the week, and then we'll jump into our priming questions, get you the answers for those, and get you on your way. So our study tip for today is going to be what I talked about in the beginning of the podcast today, is go visit physicianassistantexamreview.com/PA week. That will bring you to a very special page that's going to be up for this week and next week only. Next week, 10/6 to 10/12, I think, is PA week, right? And so we're going to be doing a lot of fun things over here at physicianassistantexamreview.com. I have some great things that have produced, and I'm producing for you for this week, and then something great for next week that I'm not going to share with you at the moment. You're just going to have to go over to the website and check it out and see what you find over there, and get you involved, and have that sort of as a little bit of a surprise for Sunday on the 6th. I'm going to reveal what I'm going to release for you, something I've been working on for a couple years now. So I think it's going to be very, very exciting. But anyway, in the meantime, this week over at physicianassistantexamreview.com/PA week, you're going to find I started to put together a video series, and the very first video is up and ready to go, and it is all about. You'll see it's. I cover some very important keys to studying, some very basic groundwork for things you absolutely have to be doing for your memory and for retention. Okay, so this is really, really big, and I go into a lot of detail, and I took a lot of time to do these, so definitely go check them out. It was so much fun to produce. It was so much fun to do, but the knowledge and the stuff in there is something you absolutely need to get your hands on. It is fantastic stuff. It is the stuff that has helped me pass exams for a long time. It's helped me to teach other people how to do it, and it's all right there on that site, so definitely go check that out, www.physicianassistantexamreview.com/PA week. There's a video today on that topic. There's 2 more videos coming, but you'll have to go check them out in order to see what's going on there. And then, like I said, I've got something special planned for PA week. So anyway, let's wrap up with our priming questions. What is Virchow's triad? I just went over it. Do you remember the 3 things? So one trick I have is, if you know it's a triad, there's 3 things, right? So you cannot just guess 2 and then get them wrong. I was just teaching this to one of the PAs. I had a doc that were in surgery, and he rattled off 6 different orders he wanted to put in specific for this patient as I'm closing, and then he scrubbed out and walked away and left. And the problem is, I'm standing there closing, which is great. I love to close, and I'm teaching the new PA how to close, and this is going well. And then we wake the patient up. We move the patient onto the stretcher, and we go to the PACU. And now there's been about 30 minutes since that doc gave me the list of very specific instructions for this patient that I had no way of writing them down, right? I'm scrubbed, I'm sterile. And how do you remember them? Well, one way I remember them is that I knew there were 6 things. So if I know there's 6, I'm not going to miss one. I'm going to work it through till I either discover all 6, or I'm going to call that doc back and ask which one I'm missing. So I know that I've got them all. So in this case, Virchow's triad, they're giving you that there are 3, right? It's a triad: immobility, hypercoagulable state, and vessel injury. Remember, it's just basically think about surgery, and you'll retain this. At least that's how I do it. Define cor pulmonale. This is right-sided heart failure secondary to severe pulmonary disease. And lastly, what is the treatment for pulmonary hypertension? You treat in secondary pulmonary hypertension, you can treat the underlying causes. There are pulmonary vasodilators, and then a lung transplant is our last step. Nope. So that'll bring us to the end of today's show. Thank you so much for joining me. I've gotten a ton of great feedback through iTunes this week. Really do appreciate that. I got a lot of feedback through the email as well. I always appreciate those. So I just wanted to say thank you to everybody who's done that, and good luck to everybody who's taken their exams this week. I really do look forward to hearing from you and hearing about the scores as you either pass or fail. Either way, I'd love to hear about it and share that moment with you. So with that being said, my music already ran out. With that being said, definitely go over to check out www.physicianassistantexamreview.com/PA week. This is 2019, by the way. If you're listening to this in the future, you will probably not find anything interesting there until, of course, if it's PA week in the year you're listening to it, and then maybe we'll have something. So anyway, I'm going to take, that's going to be it for me, and take care. Good luck. And I look forward to talking to you again next time.